It's now my pleasure to ask Dr. Dan Peterson to talk about treatment regimes for the most severe cases. Dan.
I would like to again thank the organizers for this opportunity to come here and talk about just a very limited experience that I've had over 25 years in evaluating and treating some of the most disabled people. And I hope you see this as complementary, not necessarily contradictory to other talks and things that you're going to hear later today or have already heard. And I make a plea really for, first of all, a welcome from Lake Tahoe, where we're finally beginning the spring thaw. Still looks very much that way right now. And a welcome from the Institute. And I wanted to take a second to talk about the Institute because our goal really is to practice translational medicine. And that's a big buzzword in the United States right now. But the idea behind it is that within one facility, you can take basic scientists that are going to be in one wing of this and take those discoveries they make and translate it to the bedside nearly instantaneously. And it's a concept that I'm very excited about, that communication where I can say, what do you think about this? Let's try this, let's do that, without all kinds of 5-year delays by the NIH or 25-year delays by the CDC. So that's... And I do hope we can develop some consensus and collaboration, because that is really our goal. We have a nice building that will be going up, but we have to take that next step, and it's absolutely critical. Kenny's already gone over this. Not a rare disease, but I like to look at it this way. If we had a good diagnostic marker, the potential in the United States would be at least $120 million a year. Now, some drug companies should be very interested in that, and apparently they are. Market potential for an effective therapy. On a white paper we did for this, just based on prevalence and disability, they say it's a $250 million market, which isn't great for a drug company, but it's enough to tweak their curiosity and get them interested. And of course, the price is really the price that individual patients pay. And in the US, 10% of the patients consume 70% of all healthcare dollars. It's absolutely shocking. And of this, most of it is consumed by chronic disease. And of this, ME is a significant contributor to this financial burden, not to mention the functional disability of the society at large. And again, you've seen this before, that the direct cost, just office visits, lab tests, and things like that in the US is estimated to be $7 billion by a very good study done by Leonard Jason that nobody really argues with. If you take indirect costs, it comes up to $24 billion, and that's the cost of disability, missed work, spouses missing work, et cetera, et cetera. So it's a very, very big ticket item in the United States. Of course, the CDC philosophy still irritates me. CFS is a serious illness and poses a dilemma for patients, their families, and healthcare providers. Here's NIH. For the upcoming 2-year cycle, health effects of climate change, they allotted $164 million. Mind and body, $128 million. Parkinson's, $186 million, and chronic fatigue disease, $4 million. So we're not a priority. So I was asked to talk about how I approach the really severely disabled patients. And I want to make some key points about here with respect to consensus and guidelines and establishing research protocols and diagnostic protocols so we even know that we're talking about the same group of patients. Because I think some of the problems we developed is because we're not talking about the same people. As Garth mentioned, he sees difference in the various species of mycoplasma depending on the geographic area they came from. Certainly, I've seen cases of post-Giardi. We had an outbreak in Placerville, California. 22 of those people are still sick 22 years after the outbreak of Giardi. So we have to keep those kind of differences in mind. You might say it's very easy to determine severity, just ask the patient. Well, we have to start back with consensus definitions, and we still use the Fukuda criteria. You all know these, I'm not going to go over them, but every patient that I talk about has met the Fukuda criteria. But it's not what I use, of course. I use the Canadian consensus definition, and I think it's still the best clinical definition we have out there. It should be adopted by everybody who is making a presentation or alleging to see chronic fatigue ME patients, and because we've got to be talking about the same thing. They're also useful guidelines because they're easy. It's very easy to do it. And at the end of the document, you even have some treatment suggestions, which are somewhat outdated now, but could certainly be updated if there was interest in doing a consensus kind of phenomenon. Again, it's a clinical working case definition. It includes diagnostic and treatment protocols, and it could include some consensus. No one physician is going to have all the answers to this. We have to agree almost to disagree on what our criteria are and move forward. I particularly like the Canadian consensus definition because it really emphasizes the neurocognitive part of the disease. And most of my patients who are severely ill complain more about the neurocognitive deficits than they do about the fatigue. So there's still not one unique test to diagnose CFS-ME, I think due to the non-homogeneous nature of the syndrome. And no matter what case definition you come up with, it's not going to solve this diagnostic dilemma. Nor if you use onset, rapid versus slow, et cetera, et cetera. We've tried that for 25 years and have made very little progress with respect to pinning down the exact pathogenesis. So subsetting by defining unique parameters, I think, is absolutely critical. And there may be a number of different unique parameters, and we've certainly all been looking for biomarkers for a long time. Now, one of the problems with definitions is it's not a homogeneous population to start with. Then there's biases of researchers. Somebody's looking at one part of it. Somebody's looking at the trunk of the elephant. Somebody else is looking at the tail. Somebody else is looking at the leg. It's a classic problem. Patient recruitment. There's some drug trials where they showed 90% response in some centers and 10% response in another center. It can't be the drug, it has to be the patient selection that's determining that kind of bias. So we really need to have rules about this, and anybody who publishes needs to say exactly who they're studying and the severity of illness. There's also different techniques for evaluating and following patients. I just was at a meeting where we discussed about what primers were used in our PCR reactions. That's a very sophisticated discussion, but it's very critical if you're going to end up treating somebody for a herpes virus, for example. So coming to biomarkers, this would really save the whole situation, wouldn't it? If we had a great biomarker and we could just say, yes, you fit in this subset, and here's your treatment protocol because you fit in this subset. Well, you've seen some preliminary stuff on genetic predisposition. I find that somewhat interesting, but that's not going to really help you patients who are severely affected to know that you have a genetic propensity, as it appears that you may. The gene expression studies, like Jonathan mentioned, I think have great potential for subdividing patients and even for suggesting treatments. I think that's a very exciting area that we need to pursue with much more rigor in terms of resources and funding. Causative agents may still come around from this kind of diagnostic approach. Certainly we all have seen patients, for example, that are post-Giardia. The pathology there is clear. The pathogenesis is not so clear. Viral assays as well. We have done genetic viral sequencing and assays, and there's some very interesting preliminary work there that I think Dr. Mikovits is going to talk about a bit. And the biggest rage in the United States now is these gene chips that can do multiple organisms on one little slide, up to 4,000 viruses, 400 atypical organisms, et cetera. This is a technology that's utilized in Stanford, for example. If you're admitted now for a fever, you get a little chip and it runs through 400 different organisms that cause fever, and within 20 minutes they tell you what organism you have. So let's decide who we're going to study and how we're going to study them. Well, one of the ways is self-assessment. You can all tell me if you're severely affected or not. This is a UK little definition that defines mild, moderate, severe, and very severe. And you patients can put yourself in this. It's not really a big deal, but it's very difficult to conduct research that way. That's not objective. You may say you're very severe. Somebody else may say you're not. So we do use performance tools, and I again encourage, these are standardized tools that have been around for as long as I can remember. They're used in research protocols everywhere, and they're accepted by the FDA as outcome measurements for drugs being licensed. And the first one that you've already heard about is the SF-36, very easily administered, the SLC-90, and a simple Karnofsky performance status scale. And I will tell you that oncology drugs have been licensed on an improvement of 10 points on the Karnofsky rating. So it's a very validated scoring technique that's been around forever. The SF-36 comes in an automated form now. The patient just circles it. It's also an online. You get a scoring automatically. The physician doesn't have to do anything about it. You can put it in your electronic medical records. You can follow it over time. You could say this person's developed more or less symptoms. Jonathan, again, went over some of the scales that are particularly useful on that. The SL90 is a more complicated tool. However, it's very useful because it sorts out various symptoms in great intensity. And particularly if you're doing a drug trial, you can follow what improved and what didn't. That's particularly necessary because some of the therapies we use have toxicities themselves. So if you're affecting the disease, is it really because of the therapy or is it a progression of the disease? The Karnofsky performance score is very simple. It's a global assessment. It's based on a simple questionnaire. It can be done by the patient, by the physician, or even a significant other. Again, it's validated, it's accepted in drug trials, et cetera. Here's the questionnaire you use to score. The performance rating, Kenny's talked about this before, but generally people with 40 and below are severely disabled. Now, I was once asked by the FDA, well, how do you get people with a score of 40 to do a drug trial? Because they're supposed to be bedridden. Well, it's with a great deal of difficulty, and you have to do a lot of special things for these. As the Norwegian Center is going to be set up to do, their inpatient thing I think will be very, very useful for this sort of thing because these patients are severely disabled. So what we used in the Ampligen severely disabled patient was a cutoff of 40. I find neuropsychiatric testing, which patients all bristle at because it's so exhausting in and of itself, but I find it to be very useful. And for those of you who've had it, you know how thorough it is. And I just want, here's the tests that are included on formal neuropsychometric testing. And a couple of the findings that are very reproducible. In the intelligence testing, the vast majority of severely affected patients have a big discrepancy between verbal IQ and performance IQ. And I think that's critical to this disease because the sophisticated testing has shown that you have delay in processing speed. It's not a true dementia. It's not that you don't have the data, it's that you can't get to it quickly to utilize. And formal neuropsychiatric testing will show that. It's been published many, many times, and there's even a literature now with respect to how to utilize that for Social Security, et cetera, et cetera. The verbal fluency is down, spatial relationships are down, draw a clock. Any of you patients just try to draw a clock without a visual stimulus, and you'll be surprised how poorly your clock turns out. It's been published again. I particularly like exercise tolerance testing because I can screen on the first visit for people who are truly fatigued versus perceived fatigue and these somatization disorders in which their stress testing will be normal. Everybody knows we use stress testing to evaluate cardiac disease, pulmonary disease. They're not so familiar about using it for metabolic disorders, however, but it's found to be very, very helpful in cases such as heavy metal toxicity, industrial toxic exposures, et cetera, anything that will affect mitochondrial function. All of you know what this is like. You probably, if you're a patient of mine, you've been through this. Some patients say they can't do it. In fact, I've found very few patients who actually cannot do a bicycle stress test to maximum VO2 max. Again, it's used for respiratory disease, circulatory failure, and functional aerobic impairment. There's standards in the United States that are like locked in stone. You are disabled if your VO2 max is under 20. Social Security accepts this, industrial insurers accept this, and so it's very, very useful. And it's also useful to follow improvement because it's almost impossible to train your VO2 max by simply doing an exercise program. Here's a study that was done by Van Ness et al. A few years ago, and just to give you a measurement, they had about a third of the patients who had normal VO2 maxes, but look at the severe group. It's about 10 to 12% of the patients that classify for the most severe form of impaired VO2 max. It's a very easily done test. It's standardized. It's been around for 100 years, and it's quite easy to perform. If you look at it from a circulatory failure standpoint, i.e. comparing chronic fatigue patients to patients with coronary disease or congestive heart failure, you'll actually find that most of the severely affected chronic fatigue patients are much more ill than patients with congestive heart failure. And that's a statistic that always shocks the cardiologists, but they understand it. The Pacific Fatigue Laboratory has just finished another study that I find real interesting because they found at baseline you could differentiate patients from controls in terms of VO2 max. But if you stressed about a second day, you had a very dramatic drop in performance. And every patient, again, will know this because they'll say that their fatigue becomes worse on repeat exercise. Here's an example where this particular woman had a normal VO2 max on day 1, but a markedly impaired VO2 max on day 2. So that's a little strategy that we can use sometimes to tweak people out. So for the purposes of today, we're using the CDC criteria, but I really use the Canadian consensus criteria, and we're subtyping by severity. So a diagnostic algorithm that I've developed for this is, I'm stumped, we have to wait for the autopsy. Tongue in cheek, tongue in cheek. So what we're looking at is, are there viral reservoirs in CFS patients that we can treat? That's because antivirals abound. We have lots of antivirals that we can choose from, and we're attempting to determine the state of viral expression in various tissue compartments. Perhaps looking at serum is the worst possible place we should look for a viral infection. Perhaps we should look at lymph nodes, spleens, bone marrow, brains, other places that neurotoxic viruses are known to hang out. We're also interested in identifying subsets by cytokine profiling. That's being done in a lot of other diseases. You're probably familiar with the literature on fibromyalgia, demonstrating an elevated IL-8 as a marker, and it responds to therapy, and there's just a new article out last week about this. I'm interested in patients who have gamma T cell clonal rearrangements, because this group of patients develops neoplasms, particularly hematopoietic ones such as lymphomas. And over the years, I've accumulated a group of patients that were screened by this technique. And then there's some very sophisticated genetic studies going on with STAT1 and KIR, et cetera. And I'll only titillate you with that. I won't go into the details of that. But the idea is that you may have genetic alterations of your immune system that makes you susceptible to viral infections. And this is the research that we're doing right now at the Whittemore-Peterson Institute, and you'll be hearing more about that later. I want to pause and tell you that we really, as Kenny said, do have to treat all the comorbid conditions. And how do you figure that out? Well, I do an intensive investigation. Physical exam, laboratory studies, and imaging. I'm very excited about the new idea of mass spectroscopy for brain imaging. It's been used for toxic conditions for quite a while. We sort of now thought, well, maybe it could be useful in severe cases of ME, and there's a preliminary study that suggests that that may be the case. I generally treat all of the comorbid conditions and then I reevaluate. Certainly, if somebody is hypothyroid and you treat their hypothyroidism and they don't get any better, you can move on. But it's amazing how many people I see that still haven't had the basic evaluation and treatment for comorbid conditions. And I do neuropsychometric testing on all the patients because I find it very useful to measure the cognitive dysfunction. SPECT scans, which I'm sure we'll hear more about in a bit, typically demonstrate regional hypoperfusion. Immunological profiling, a whole talk could be based on the findings of low natural killer cell activity, activation of the antiviral pathway. This is how I arrive at the patients who can benefit from antiviral therapy. So there may be unique host expression signatures that we can use to redefine the disease. These signatures may be predictive of a susceptibility to the disease that we call CFS-ME. And there may be unique expression signatures that can actually predict therapy. And this is our real goal in the immediate future. In the next couple of years, refine this so that we don't have this generalized discussion about what are we treating and how we should treat it. A word on prognosis. Many of you here know the CDC's dismal statistics that if you've been sick more than 5 years, you're going to stay sick. You are not going to have a spontaneous recovery. So I've learned the hard way that aggressive strategy is required earlier rather than later, and it's absolutely justified in such a disabling disease. This is complicated a bit, and we get into trouble with this when we design trials because the FDA says, yeah, but the symptoms come and go, and how can you attribute improvement to a fluctuating disease? And there are some ways around that as well, and the basic answer is objective markers. So looking quickly at the subset of viruses, if you search the literature, You'll find a lot of supporting document that say viruses may have something to do with severe ME. Mostly, as you noted, it's the herpesviruses, the enteroviruses, and parvoviruses. I think that literature is pretty good, and it applies to subsets of patients. This Andrew Lloyd study showed prospectively that patients after acute documented infections could go on to have chronic fatigue-like illness. However, they may not have persistent organisms present. They may have an abnormality of the immune system. The herpes viruses are attractive to look at because they're ubiquitous, they're tough viruses for humans to handle, they reactivate, and they cause illness. So they're a very attractive group. I point out that there's 3 families of herpes viruses, the alpha, beta, and gamma viruses, and that's because they have different sensitivities to antivirals. So you have to be very, very careful knowing exactly which herpes virus is reactivated before you attempt to treat it with an antiviral. HHV6, for example, is not at all sensitive to acyclovir, as an example. Here's a study that showed HHV6 in patients with chronic fatigue syndrome about 15 to 25%. I think other studies from around the world have shown reactivation of HHV6 as well. We can get into a discussion about whether it's variant A or variant B. Epstein-Barr virus may stimulate cytokines and may produce its own problems through the production of immune aberrations rather than the effects of the virus itself. We know it's associated with the development of tumors eventually, and we know that EB is often cohabiting with other virals and other organisms as well. Parvovirus is a great literature about post-parvo infection. Parvovirus is quite treatable these days with certain interventions, so I screen for parvovirus. We'll hear much more about enterovirus later, but they're very attractive, particularly in view of their ubiquitous nature in the GI tract and their ability to affect the brain and other organs of critical nature for ME. Bornavirus has been reported from Japan. I don't personally find that. It might, again, be a regional difference that we don't particularly have that virus in the Western United States. So in summary, I think patients may have increased vulnerability to viral infections, particularly the herpes family. This may result in an increase in viral burden. Perhaps there's impaired immune surveillance, particularly low natural killer cell function that's been reported by basically every immunologist who's ever looked at severe ME. And there may be specific antiviral defects that we're looking through in the genetic studies. We did do viral array studies that showed a prevalence of herpes viruses in these patients, but also a multitude of infections. Getting back to Dr. Nicholson, it was shocking how many viruses these patients would have, multiple viruses at one time, whereas the control group typically had what you'd expect with adenoviruses, rhinoviruses, and similar common organisms that you would expect in a control population. Again, why am I interested in gamma T cell clonal rearrangement? Because it may suggest an active viral infection, particularly CMV, which is something that we may have overlooked. And I'm particularly interested because it does predict the development of neoplastic disorders. So we all know the model that's been postulated, genetic predisposition, triggering events, mediators. How can we detect the people that should be treated? And here's an algorithm I use to detect herpes in the spinal fluid. The patients must meet the Canadian consensus definition. They have CNS complaints. They have an abnormal MRI and an abnormal SPECT scan. They have abnormal cerebral spinal fluid with increased opening pressure, increased lymphocytosis, and increased total protein. And then if they have a positive viral culture or PCR, I think that's adequate justification to treat them. Their CNS complaints are headaches, neurocognitive impairments, paresthesias, autonomic dysfunction. Again, the neurological complaints. Abnormal MRIs with those increase in T2-weighted images that you saw from the Norwegian patients. Abnormal spinal fluid. Negative oligoclonal banding, so for those MS doctors, this does not appear to be MS. And of the viruses, 44 were positive out of the 279 that have been done, or about 16%. Again, this correlates with the severity of patients. There was 1 positive for EBV, 1 for CMV, and 42 positive for HHV6. These were all variant A. And you would expect that because HHV6 variant A is a neurotrophic virus. So, coming down to treatment. Well, it's still symptomatic, 25 years and counting. And that's not to ignore symptomatic therapy. I think it's very helpful, but it certainly is not going to help a severely disabled patient recover. So what were we left with? Immune modulatory agents, antivirals, or specific therapy based on subset pathogenesis, as Jonathan suggested, if we can identify those groups. What we've been doing is looking at this multitude of factors that are involved in these patients and doing some sort of symptomatic therapy, which hasn't been enormously successful in restoring the health of the severely disabled. It is certainly helpful in the patients who are lesser disabled. This is the clinical paradigm that we've been using. You have an illness, we evaluate, we do more testing, we try something, we do more testing, we try something else. If you're still ill, we go around the circle again and again and again and again, hoping for recovery. And the new model that I mentioned earlier is one that says, no, we need to do updated rapid diagnostics that are validated to short-circuit this pathway so we don't have to make all the errors in clinical judgment and we don't have to wait and see what happens. And that's a strategy behind translational medicine. So in general, it's been said before, I create a supportive environment. I certainly educate medical personnel, family, and the legal system. I totally agree with the Norwegian model with respect to those kinds of issues. Nutritional is the first thing I take on. As I was taught many years ago, I alter the diet even before I get the tests back. Some of these patients require hyperalimentation. It's amazing as soon as you begin hyperalimentation how much they'll perk up. They've been malnourished for many, many years sometimes, and that contributes in large part. There's a new technique in the US using peripheral hyperalimentation because it can be done if it's diluted appropriately and you don't have to have a central line and all the nuisance that goes along with that. Supplements certainly are beneficial. We've heard about those. Rehabilitation and coping. I'll make a word about CBT. I do find it useful. However, you need somebody who's very good at it, which I don't have, and you need somebody who's willing to see the patients through a long term because they get relapses after CBT. Pacing, I agree with. Graded exercise. Be very, very cautious on that. Graded exercise for my severely disabled patient is stretching. It's not jumping on the treadmill and running for 20 minutes. And that's very difficult to teach physical therapists and other people who are involved in this field. They simply don't understand how severe the disability is. So what I do with my physical therapist, I show them the treadmill performance. I show them the VO2 max of 10. He goes, oh my gosh, this patient's almost dead. Better start with some stretching. I say, that's what we should do. Adjuvant therapy, counseling, massage, group therapy, legal assistance. Of course, we do these things. I think they're critical. They're going to be part of the Institute. More targeted therapy, antiviral therapy and immune modulatory therapy. And the two big immune modulatory agents we have is Ampligen and intravenous gamma globulin. I certainly treat intestinal dysbiosis and increased permeability as well. I use many of the same analyses that Dr. Demurier talked about. Here's one of the tests I do, Genova Diagnostics for intestinal permeability. It comes back pretty quickly. Again, it shows, quotes, leaky gut syndrome. Here's a treatment that comes from University of California in San Francisco where they use Xifaxan, Flagyl, and then followed by probiotics. There's many, many regimens. There's no magic to this particular one. Here's something I want to pause on, treatment of orthostatic intolerance. Because I've found that in the severely affected patients, one of the things that keeps them down is they're dizzy and weak on every attempt to get up. So after a while, they have no incentive to try to get up, much less they pass out, they hit their heads, they have some injury. So orthostatic intolerance has been studied pretty widely now, and there's various forms of it: multi-system atrophy, pure autonomic failure, autoimmune autonomic neuropathy, and what's alleged to be most common in chronic fatigue syndrome is postural orthostatic tachycardia syndrome, where your blood pressure drops and your pulse rate goes up. It's really interesting following the research of this. There's families that have norepinephrine transporter deficiencies. There's polymorphism in the genes controlling the autonomic nervous system. And I'm sure in that field, the research is going on and on with respect to specific treatments. There are certainly non-pharmacological measures that we physicians all tell patients: don't get up quickly, stop taking your blood pressure medicine, increase your salt, et cetera, et cetera. But for the severe patients, this won't really affect their function. You don't need a formal tilt table test to do this. You can simply stand these people up in the office and monitor them. I'm particularly interested in the latest research using immunomodulatory therapy for dysautonomia, because I didn't believe this at first until I read about the third study, using intravenous gamma globulin, a fairly high dose for 2 to 5 days with normalization of autonomic function. And this implies that intravenous gamma globulin has an immunomodulatory action to affect the autonomic nervous system. And there are theories why that would be effective. Fluorine-F, it's widely used in the United States. I find it doesn't work particularly well, and all the patients complain about fluid retention. Alpha agents such as midodrine can be useful for the severe cases, but again, it's fraught with a lot of side effects and is not tolerated particularly well, but it can be very useful for the patients that really bottom out their blood pressure. Beta blocking agents are theoretically useful. The problem is that it makes blood pressure worse, lowers pulse rate, and is very, very difficult to administer in a chronic disabled patient, in my experience. Vasopressors we don't particularly use. Erythropoietin is interesting because there's been 2 studies done showing a benefit because of the anemia of autonomic dysfunction, not the anemia associated with iron deficiency or other causes such as anemia of chronic disease. And it has a unique use, and I'll show you an example of that when we get to the case stories. Immunoglobulins, my patients often tell me if there's one thing I've done for them that were severely affected and they had to go to a desert island, is intravenous gamma globulin. It's a very potent immune modulator. It neutralizes circulating myelin. It downregulates pro-inflammatory cytokines, has a wide effect on the immune system, and just recently came out in a sub-Q form, making it much, much easier to administer. Patients can do it in their homes, and it's a beneficial therapy for a subset of patients. Our treatments currently for viral infections, well, there's a list of drugs that may or may not be effective. Foscarnet is very toxic. Valsite I won't discuss. You probably know that Dr. Montoya at Stanford just completed a double-blind placebo-controlled trial of Valsite in patients who had elevated EBV titers, and he reported positive effects from that study. But of course, a phase 3 trial would have to be done. The patients who have documented evidence of HHV6 variant A, we are stuck using either ganciclovir, which is very tedious and difficult and dangerous to use, or cidofovir, which I've come to using cidofovir because of lower toxicity and better control. And then there's Ampogen, poly-I, poly-C12U. Ampogen, you know, has been in clinical trials for over 20 years, and this week the FDA put it on hold once again, stating that they did not have the personnel to evaluate the application. But hopefully that's just a temporizing delay. It is felt to work on toll-like receptor 3s and modulate the immune system. It also may have other direct antiviral activities, and it's felt to be a tumor anti-proliferative as well. Here are the patients that we've treated under this very, very tight protocol over the past 5 years with patients with documented CNS infections. And the largest treatment group of severely affected patients has been with Ampogen. As many of you know, this was a 10-center study that was done at multi-sites. So I just wanted to close by some case studies that I think might be useful to the patients as well as to the treating physicians. The first is a 36-year-old female author, ill for approximately 10 years with a flu-like illness, was bed confined due to orthostatic intolerance, had marked cognitive dysfunction, myalgias, arthralgias, and exercise intolerance. Her stress test had a VO2 max of under 15 milliliters per kilogram per minute, which put her in the severely disabled category. She had marked amino acid deficiencies of the plasma and urine, implying long-standing leaky gut syndrome, a very low NK cell function, IgG subclass 3 deficiency, and evidence of EB reactivation. Her Karnofsky score was 40. She was initially begun in intravenous gamma globulin, amino acids IV, and Valtrex 500 milligrams BID. And on this regimen, in approximately 1 year, she reported feeling nearly 100%. She continues IM gamma globulin, cognitively impaired. She was able to now write a children's book. She amazingly, after 10 years of trying, became pregnant, delivered a healthy baby, did not have a relapse of symptoms during or after the pregnancy, and the last time I saw her maintained her Karnofsky score of 90, which is minimal symptoms. Case number 2 is a 49-year-old male contractor and carpenter, and I'm afraid this is the kind of case that I was missing for many years and is a real tragedy. This particular man reported cognitive deficits in June of 2006, marked malaise and fatigue, and a history of meningitis. He was positive for HHV6 in the plasma, his RNA-seL was elevated, early antigen for EBV was elevated, his MRI scan demonstrated marked changes of the left temporal lobe, and his SPECT scan demonstrated complete absence of activity in the left temporal lobe. By August of 2006, he could no longer read, he was disoriented, had marked cognitive problems, his Karnofsky score was now 30, and he was required to live in a nursing home. By October of 2006, he was now taking 13 medications prescribed by the nursing home doctors, including Neurontin, Dilactin, Lamictal, etc., with no improvement. At that point in time, he had a lumbar puncture with the findings of HHV6 variant A positivity. In December, the patient was begun Investide, 5 milligrams per kilogram, Q2 weeks, and was treated for 1 year. By February 2007, he was feeling significantly better. He was carefully monitored for toxicity, which is renal toxicity and hematopoietic toxicity. In July of 2007, he was on 3 medications, Dilantin, Klonopin, and Celexa. His cognition was improved. His neuropsych assessment revealed only mild impairment in learning, processing speed, and mood, which one would predict from his temporal lobe problems. And here's his viral loads, and this is comparing his spinal fluid before and after treatment and his serum before and after, and both reached negative status. He began free amine for his leaky gut syndrome, and he returned to work as a carpenter and left the nursing home. The third case is a 53-year-old female surgeon, severely ill with ME, cognitive dysfunction, low IgG subclasses. She had comorbid diseases, is the point I want to make here. Marked obesity, hormonal deficiency, hypothyroidism, and a Karnofsky rating of 30. She was unable to operate, obviously. In fact, I took her out of work because I thought it was very dangerous for her to attempt to continue operating. She qualified for the Ampligen 511 compassionate care protocol. She was feeling much better by March of 2002, thinking more clearly. She was able to think so much better and function so much better that she was able to undergo a total knee replacement. She continued on Ampligen and intravenous gamma globulin. By February of 2004, about a year later, she was almost back to normal and was working full-time with a Karnofsky rating of 80. In September of 2004, I began an Ampligen holiday. The patient had an almost immediate relapse of symptoms, feeling not well. Repeat testing, and again, this is how we can utilize this to monitor these patients, showed a decrease in VO2 max. Her NK cell function was again down to 4%, compatible with her clinical relapse. She resumed Ampligen, 400 milligrams IV twice weekly. She continued intravenous gamma globulin. 5 years later, she continues full-time work as a surgeon and won't allow me to go on Ampligen holidays. Case number 4 is a 49-year-old female entrepreneur. Again, characteristics severe ME, sleep disturbances, documented EBV infection in 2003. She experienced weight loss, secondary depression. Her exam was remarkable for significant adenopathy that one might expect in a persistent EBV infection. She did begin some supplements. Again, she had, interestingly, hematocrit of 32 with normal folate, B12, and iron studies, low natural killer cell function, low urinary amino acids, and low IgG subclass 3. She discontinued her psychiatric medications and gained some weight. She began intravenous gamma globulin. She was found to be persistently hypotensive. She was positive by antigenemia for HHV6. I began her on, as part of her therapy, on saline plus Procrit, a standard regimen for orthostatic intolerance in that group of patients I showed you earlier with severe orthostatic intolerance. She was substantially improved, which she attributed to the saline infusions in gamma globulin. On Procrit, her blood pressure improved to 120/70, and her hematocrit increased only to 35. She did not develop a polycythemia. Her NK cell function improved to 37 lytic units, and her other parameters normalized. By January of 2007, she was feeling better and able to return to her business. And the last case I wanted to show is a 55-year-old female, first diagnosed with Tahoe flu in the 90s. She developed seizures, which were non-epileptogenic seizures, which is generally what we see in this group of patients. That question was asked earlier, accompanied by these unidentified bright objects on MRI scanning. Her serum and spinal fluid done by the protocol I showed you earlier was positive for HHV6 variant A. She interestingly has germline chromosomal integration. And HHV6 is the only herpes virus that's known to integrate into the genetic code. She developed a clonal T cell rearrangement. Vistide therapy was begun in 2007 with a marked improvement in her symptoms. And here's her viral load, and I'll make several points on this. After treatment with Vistide and her improvement, her viral load did drop to undetectable in the spinal fluid. Her serum viral load was 46,000 to begin with, dropped to 3,000. That's what you would expect in somebody chromosomally integrated. They have very, very high viral loads. It's a tip-off to somebody who's chromosomally integrated, and you never eradicate the virus because it's part of your genetic code. You simply impair its replication. So this is a rare case, but one of those that we can find if we do this kind of intensive evaluation. And again, she's functioning at a Karnofsky score of about 80. So I hope I've tweaked your curiosity about the use of translational medicine and the kinds of things we're trying to do to very, very aggressively diagnose and treat the most disabled patients with CFS-ME. Thank you.
You will agree that was a fantastic talk. Important questions now. Lady at the back.
Here we are. Carmen Scheibenbogen from the Charité in Berlin. As you have so much experience with so many patients, I would be curious to get an estimate from you. First is how many patients do have a viral-associated CFS, and in how many patients are antiviral successful? And second question, how frequently is Ampligen successful, and are there criteria which patients are more likely to respond to therapy?
The answer to the first question, about 15% of the patients have evidence of viral activity or a viral role in there. So it's not the vast majority of patients at all, and we never allege that. It's a group that we should identify because they're pretty straightforward in terms of treatment strategy. Most of those patients, these are not unusual cases that I showed today. With respect to Ampligen, the success rate with Ampligen is around 70% if you select properly. And that's a big issue that the drug manufacturer has faced, is what patients should be treated, how long should they be treated, et cetera. And those of us who have learned this by trial and error, we have some ideas about that, but the exact criteria are not clear. There was one center in the Ampligen trials that had 100% dropout and no responses. So it's clear that you have to know what kind of patient you're treating. And of course, I don't have it available to me except under compassionate care for a very few number of patients.
I have a question. We both do the same intervention when we first see a patient. Roughly how many of your patients get better with that intervention?
Oh, the vast majority have a symptomatic improvement.
Just tell them what it is.
Probably 50% of the patients have significant functional improvement, especially with the GI complaints. It's the first intervention I make.